Great. So thanks very much for having me here today. This is what I will give you is an overview of how we think about improving healthcare delivery and payment in two parts. This will be 10 minutes. So part one will just be some of the broader common themes we see across our work and what we're trying to do across the delivery system. And then part two, I will give you a very quick synopsis of two specific models that we're testing in the field, the Pioneer ACO model and the Comprehensive Primary Care Initiative. But at a very high level, the Innovation Center was created to change the way that we pay for care, deliver care in the United States. My basic thesis, our thesis, is that payment and delivery are inextricably linked for two reasons. So number one, changes in payment can induce changes in healthcare delivery. And number two, any successful delivery model requires some long-term financing mechanism. So providers need some way of financing changes in healthcare delivery, enhanced care management, and preventative care. The second sort of high-level observation I would share is that, and I think, Randy, this is very much in line with your last slide. At this point, the Innovation Center is 5 years old. We have an early abstract understanding of what some of the common attributes are of successful models. And so just to share some of them, and I think this was sort of the gist of your presentation, successful delivery models, they work in teams. The providers provide enhanced access. They're proactive about using continuous data to improve care. They work across the medical neighborhood with a very select group of medical subspecialists. They engage their patients in shared decision making, and they risk stratify their patients. So the subject of the entire morning of discussion here. I think the challenge for us has been, and the challenge perhaps for this room, is moving beyond that abstract understanding to a very specific understanding. And by a specific understanding, I mean a specific set of operational imperatives, a playbook, if you will, that we can actually package and deliver to providers as part of a change package. And my request as a frontline policymaker, it's not my place to challenge this group, but my request of you would be to help get us there. That would be the single most important thing that I would convey today, is to help us move from that abstract understanding to a very specific understanding of the operational changes that are required to move providers there. So broadly, the Innovation Center is doing three big things. So number one, changing payment, so changing the frontline incentives that providers face. Number two is giving providers the tools they need to be successful. And number three is getting data, both to providers and to Medicare beneficiaries, to help them make better decisions about their care. Broadly, all Innovation Center models impact high-need patients in one of two ways. So there are some CMMI models where we actually segment populations. So an example of this would be independence at home, which is for really the upper end of the cost curve for Medicare patients, where we have a specific home-based primary care delivery model specifically for extremely high-cost Medicare patients. And then I would say the vast majority of models, we set the table for providers and give them broad population-based incentives, but we ask the providers to segment their own populations. So two different approaches, and the two models I've picked out to talk about are one of each. So Pioneer ACOs are looking at a broad Medicare population, and then the Comprehensive Primary Care Initiative, we actually give providers some more of the basic tools. One more high-level slide. Many of you are undoubtedly familiar with this, but the Secretary early in 2015 set high-level goals for payment reform. So in 2011, 0% of Medicare fee-for-service payments were in alternative payment models. At the time that she made this announcement, 20%. And the goals were that we would move 30% into alternative payment models by the end of 2016. We will hit this goal sometime in 2016, and 50% by the end of 2018. We'll skip over some of these slides just in the interest of time. This is just a slide that shows Medicare per capita expenditure plotted against per capita GDP growth. This is a slide that shows ACO penetration across the country. we now have over 8 million Medicare beneficiaries assigned to Medicare ACOs. The vast majority of these are in the Medicare Shared Savings Program. I see Terry here. The model that I will talk about is the Pioneer ACO model. So this is the close cousin of the Medicare Shared Savings Program. This is a model operated by the Innovation Center. It was the first model launched by the Innovation Center. And this was a model for, this is a model for healthcare organizations that have some experience in managing population health, and we're willing to be pioneers or leaders in the field and take on two-sided risk. Medicare has a long history of producing demonstrations and models. There's also a long history of these models not working over 30 years, as Ashish Jha is very fond of pointing out on Twitter. And this is a model that actually worked for 3 years in a row. So in year one, $92 million in actuarial savings, $96 million in year two, $120 million in year three. This is all the while there was attrition in the program. So the average savings per ACO actually increased from 2.7 million in year one to 6.0 million in year three. Independent of this, an independent evaluation that compared the pioneers to a matched comparison group showed 2-year savings of $385 million. Mean quality score, the composite score across 33 quality measures, increased from 72% to 85% to 87% from years 1 to 2 to 3. These numbers don't mean a lot in abstract, but what this means is that in year one, the pioneers beat the national benchmarks on 15 out of 15 quality measures for which we have comparable national benchmarks, 4 out of 4 patient experience measures. Now in the Pioneer program, CMS is not prescriptive about the delivery model. But what we do is bring the pioneers together to learn from one another about best practices, to learn about delivery innovation. And in this learning system that we offer to the pioneers, one of the tracks is on population segmentation. And so the discussion that you had this morning would be an example of a quarter one discussion that the pioneers might have had. And I think one of the things I would invite you all to is to participate in our learning system. And if you would really like to see how some of our frontline providers are working with the tools and the concepts that you all are developing, this would be a good place to do it. We'll skip over the independence at home model just in the interest of time, but happy to dive into it if folks have more questions. But I think the relevant point about independence at home is that this is a model where we have actually segmented the population as a payer. And we have said we're going to offer a shared savings opportunity to providers that provide home-based primary care for extremely high-cost Medicare beneficiaries. We have 1 year of results from this model, things change from year to year in Medicare demonstration land. But in year one, this demonstration produced $25 million in savings, about $30,000 per beneficiary in the first year. The Comprehensive Primary Care Initiative is a medical home model in 7 markets around the country, where we launched this model in partnership with about 30 payers in these 7 markets. We are making coordinated investments in advanced primary care. It's about 500 practices, about 300,000 Medicare beneficiaries, and then about 2.5 million total patients if you include all payers. On the Medicare side, we make a monthly payment of $20 per Benny per month in years 1 and 2. That drops to $15 in years 3 and 4. And there's an opportunity for practices to earn shared savings on reductions in total Part A and B Medicare expenditures. The basic care delivery approach in the comprehensive primary care model is that practices start by impaneling their patients and risk stratifying them. And then we ask them to engage in care management, including care planning, use of registries, proactive care monitoring, enhanced access, including non-visit-based care, and team-based care. We are not prescriptive per se, but we do ask providers to stay within certain broad lanes. So we ask that their care management activities include one of the following. So behavioral health integration, self-management or support for beneficiaries, and or medication management. And then we give the practices milestones that we expect them to meet over 4 years. That's what we're paying for in these care management fees. And the milestones are very broad. It's have a budget for how you're going to use these care management fees. Provide 24/7 access and continuity. Engage patients in care redesign and shared decision making. Perform data-driven continuous quality improvement. Coordinate care across the medical neighborhood. Participate in our learning system, and use health IT. At a very high level, we have results, quantitative results that we've released from the first year evaluation. I think they're on this slide, that showed a reduction in Part A and B expenditure about $14 per beneficiary per month. So that is not quite enough to offset the investment that we're making. On quality, I would say that the results were somewhat mixed. We saw statistically significant effects on claims-based quality measures for diabetes care for high-risk beneficiaries. But beyond that, no statistically significant effects in the first year. Just to level set, it is generally not our expectation that these models will produce blockbuster results in their first years. So the Pioneer ACO model was very much an outlier in that sense. And to us, this is an early but a promising result and worthy of further study in years 2 through 4. These are actuarial results from year 2 that show 6 of 7 regions showed gross savings, 1 of 7 regions showed net savings, and then 2 regions actually showed gross losses. So stay tuned for further results here. On the qualitative side, virtually all of the practices met their milestones. Nearly all 500 practices met their milestones in year 1. 93% of them implemented risk-stratified care management. We found that even at that high level of meeting that milestone, there was some correlation between high functioning status and having a high function in HIT system and care-based care. So having pre-existing infrastructure is what I'm trying to say. So overall, just to come back to these global points, we're at a phase now where we have been in operations for 5 years. The Innovation Center is a unique construct within government where we are both operators, but we are also research scientists. And both on the payment side and on the delivery side, very much trying to figure out what works. And to me, the core challenge for the next 5 years is moving beyond this abstract understanding of what constitutes an effective care delivery model, and actually being able to understand it in very specific terms and deliver it as part of a change package at national scale. So really look forward to your questions and very happy to receive your feedback and dive as deeply as you'd like into these models or any one of our models. Thank you.